Good morning, everyone, and thank you for joining us. My name is Steph Kershaw, and I'm a postdoctoral research fellow at the Matilda Centre for Research in Mental Health and Substance Use, and I'm also the project coordinator for Cracks in the Ice, which is an online toolkit. And it's my really great pleasure to welcome you to today's Cracks in the Ice webinar. Before we begin our webinar, I'd just like to acknowledge the traditional owners of Australia and recognise their continuing connection to land, water and culture. I'm currently on the land of the Gadigal people of the Eora Nation, and I pay my respects to their elders past and present. I'd also like to further acknowledge the traditional owners of the country on which any of our attendees are joining from, and pay my respects to their elders past and present. So as many of you know, today's presentation is one in a series of webinars focused on methamphetamine and its effects on the Australian community and internationally. And if you haven't already seen the Cracks in the Ice website, I'd like to encourage you to visit it. And you can also catch up on any of our previous webinars there. Before I introduce today's speaker, I'd just like to let you all know that as participants, you are in listen-only mode. And this means that we can't see or hear you. However, you will notice that you have a Q&A button on your dashboard, and this is where you can type in any questions that you have during the webinar and send them through to us. We will then have a question and answer section at the end of our webinar. I'd also like to let you know that we are recording today's session, and we'll be making the recording available through the Cracks in the Ice website. Now, it's my very great pleasure to welcome today's speaker, Professor Richard Rawson, who is a Professor Emeritus at the University of California, Los Angeles, Department of Psychiatry, and a research professor at the Vermont Center for Behavior and Health at the University of Vermont. He received a PhD in experimental psychology in 1974, and he has Professor Rawson has conducted numerous clinical trials on pharmacological and psychosocial behavioral addiction treatments for the treatment of individuals with cocaine and methamphetamine disorders. He has also led addiction research and training projects for the United Nations, the World Health Organization, and the US State Department, exporting science-based knowledge to many parts of the world. Professor Rawson has published 3 books, 40 book chapters, and over 250 peer-reviewed articles, and has conducted over 1,000 workshops, presentations, and training sessions. So we're extremely privileged to have him join us today. I'm sure it's going to be an excellent presentation as he takes us through what are the evidence-based treatment options for methamphetamine. So over to you, Professor Rawson.
Thank you, Steph. It's a pleasure to talk with you. Zoom is a wonderful tool. I've done a lot of these in the US, but this is my first one with Australia. So I'm very excited to be able to talk with you. I know some of the researchers in Australia. Australia is known around the world as having one of probably the best per capita addiction research community in the world. And I use a lot of the research from Australia in the work I do. As Steph mentioned, I've been doing this work since 1974. When I started work in Los Angeles, treating individuals for heroin use disorder. And then starting in about 1980, we started to see large numbers of people entering treatment for problems related to their cocaine use and then their methamphetamine use. And for about 30 years, most of the work I did was on developing behavioral and medication treatments for people with cocaine and methamphetamine use disorder. And so I'll try to give you some perspective on where things stand today. There is just a great article in the Atlantic magazine that was published in December on the new methamphetamine that we're seeing coming in from Mexico, made with a new formula and a new precursor that's producing much more lethal methamphetamine than we saw during the main part of my career, much higher potency and much greater lethality from the methamphetamine itself. And part of why the US and why I'm back doing work, I left UCLA, I left my Los Angeles 6 years ago and moved back to my home in Vermont, where I have an animal rescue. And I thought my career of doing talks was pretty much over because we were right smack in the middle of the opioid epidemic. And there wasn't a lot of interest at that time in work with stimulant, individuals who use stimulants. However, we've seen a resurgence of stimulant use in the US and much more lethal consequences. This gives you a picture of the overdose death pattern in the United States over the last 20 years. And I won't go into detail, but looking at the 2019 numbers, you see there's two drivers of the overdose death crisis: synthetic opioids, which is fentanyl, and blue, which is cocaine and methamphetamine, predominantly methamphetamine. Now, these numbers were 70,000 deaths in 2019. This exceeded 100,000 in 2020. The pandemic has had a tremendously severe impact on overdose deaths in the US. The combination of the pandemic and fentanyl have really been a tremendously serious public health crisis. But also methamphetamine has spread and it's more lethal, and much of it now includes fentanyl. So we have really like a perfect storm of bad stuff for people who are using these drugs. Many of the individuals who have died of fentanyl overdoses have purchased the drug they think is methamphetamine only to die of an opioid overdose. Plus, we're also seeing a considerable number of methamphetamine overdose deaths, which we never really did see very many of during my the main part of my career, 1990 through 2010. The methamphetamine was certainly potent and caused lots of clinical problems, but not overdose deaths. Now these drugs are causing deaths at very high rates, and it really is really changed the much of the focus and priority of treatment in the US. We're seeing a much greater appreciation for harm reduction strategies and a much greater focus on what can we do to keep people from dying, as opposed to our old focus, which was almost exclusively on helping people become abstinent, totally abstinent from drugs. So it's created a big shift, in part because of the increased death rate that we're seeing from these drugs. These are some of the clinical challenges. As I do clinical training, sometimes we're talking about what is it that these folks with who are using methamphetamine, what's the thing? What does the disorder look like? Well, these are some of the clinical challenges. Obviously, overdose death is number one. They have a limited understanding of the fact that they're addicted. Many of them have colleagues and friends or family members addicted to opioids, and they say, well, that person is addicted. They have to use 3 or 4 times a day or they get sick and they can't stop. I can stop when I want to, so I'm not addicted. So there's one issue is that many of them are not really understanding of the nature of their addiction. And if they don't think they're addicted, they're ambivalent about the need to stop. And so you have a lot of folks, and I'll show you some data on this, that are not particularly interested in treatment, stopping their use or even reducing their use. The drug produces very dramatic changes in the brain, which lead to impulsivity and poor judgment. I'm sure some of them had impulsivity and poor judgment before they ever took their first dose, but it becomes much worse with their chronic stimulant use. Severe cognitive impairment. There's an article by Martin Paulus that was published last year in JAMA on reviewing the data on cognition and methamphetamine that really documents quite clearly how severely their cognition is impaired. They have ongoing paranoia. Sometimes it blossoms into full psychotic paranoia, but even when it's not psychotic paranoia, they have this low-grade paranoia that makes it more difficult for them to engage in treatment, among other things. The hallmark is anhedonia, which is caused by the downregulation of the dopamine system, where they have this flat life just sort of is gray and nothing feels good. They have an absence of pleasure. Anhedonia means the inability to experience pleasure. So they stop taking this drug that produces these massive highs and rushes, and now everything feels kind of gray. And that often is part of the fabric of their relapse. Hypersexuality when they're using. When they stop using, they often become sexually dysfunctional, and that of course is concerning to them. Psychosis, elevated levels of violence. Took that one from an Australian paper. They're the sort of the hub of their addiction is this powerful craving they get that's created by a Pavlovian conditioned response, so that certain things, cues, people, places, things, times of day, emotional states can produce this craving. And the individual who uses doesn't understand the craving. All they know is they're cruising along and all of a sudden, all they can think about is they want to use. And they're hard to retain in outpatient treatment. Retention is very poor in outpatient treatment. So those are some of the clinical challenges. This is a study published in last year from the state of Washington that gets at this issue of their ambivalence about interest in reducing their use. This was a sample of 583 participants in a Washington state syringe exchange. About 2/3 were primary opioid users. About a third were individuals who primarily used methamphetamine. They gave them a battery of questions and a survey. 82% of the individuals who reported opioids as their main drug expressed an interest in reducing or stopping their opioid use. That is, at some point in the future, they felt they would need to reduce their use, stop their use, and or get into treatment. Less than half of the individuals who reported methamphetamine as their main drug expressed this same feeling. Now, this is probably both partially due to the drug effect and partially due to the availability of treatments. The individuals who use opioids know there are treatments like methadone and buprenorphine that have some benefits. The individuals who use methamphetamine know there are not such medications. And so when you talk to them about the available treatment being counseling, they're not quite as enthusiastic about that as an option. Once you get them into treatment, they're harder to keep in treatment. This is a study last year, meta-analysis of psychosocial substance use disorder treatment. And it looked at dropout rates in the first 90 days of treatment, 151 studies, 27,000 participants. And this is the dropout rate in the first 90 days by drug of use. For individuals who use heroin, you get about a 25% dropout rate in the first 90 days. Now, of course, with heroin, we have medicines like buprenorphine and methadone. And if we didn't, that number would be much, much higher, but luckily we do. Tobacco, you get about a 25% dropout. Alcohol, about the same. With cocaine, it's about double that, almost 50%. And with methamphetamine, it's over 50%. So you have these individuals who use methamphetamine, they're harder to get into treatment and harder to keep in treatment. There are a couple of groups, there's a number of groups that I think are particularly noteworthy for needing special consideration for treatment. Individuals who inject stimulants and those who use stimulants daily or in very high doses. It's not as though it's sort of a linear thing that if you use 5 days a month, you have one level of addiction. If you use 15 days a month, you have another level. And if you use 30, it's much more like there is a linear approach. And then when you get to the really heavy users or injectors, things get much, much worse in terms of their prognosis, their medical problems, their psychiatric problems, their social problems. And so those two groups tend to have much more severe problems and often need to start treatment in a restricted environment. It's very hard to start them directly into outpatient treatment. There's some other groups there as well that have special needs and special twists to their treatment. As I mentioned, we're now doing, in the US, we're now doing a lot more harm reduction, although the harm reduction strategies for people with stimulant use disorder in the United States are much less well developed The biggest one right now is people testing the methamphetamine for fentanyl, because much of the methamphetamine supply has fentanyl in it. And so there's a lot of distribution of fentanyl test strips as a for the people who are buying methamphetamine to be able to test it to see whether or not it has fentanyl. Now, if it does have fentanyl, it doesn't mean they won't use it. In fact, as I was talking to Steph beforehand, we're starting to get some information that many of the individuals who are out now buying methamphetamine will only buy it if it has fentanyl in it. They like the combinations, even though it is incredibly dangerous and very lethal. But the other thing, syringe exchanges, naloxone, again, given to someone who's an individual who uses methamphetamine doesn't necessarily make any sense, except for the fact that much of their methamphetamine has fentanyl in it. And so you may need the naloxone to reduce a fentanyl overdose, and some other strategies as well. But this still needs a lot more development, as the US has only recently in the last few years recognized harm reduction as a thing that is important to integrate into our health system. As I said, I moved back here to Vermont 6 years ago, and I was interested. I spent 20 years sitting in a room talking to patients and developing treatments and doing medication trials and a variety of things, but it had been a while. So I decided to go out and interview 25 folks who were on buprenorphine or methadone for their opioid use disorder, but were also using stimulants, mostly cocaine. Here in Vermont, methamphetamine has only recently arrived, but they were using either cocaine or methamphetamine, because I wanted to find out what they thought about the need for treatment. So I asked them a bunch of questions. One was, do you consider your stimulant use a significant problem in your life? 23 of the 25 said no. So the first order of business was their prescribers, their buprenorphine and methadone prescribers viewed their stimulant use as a problem, but the individual didn't see it that way. When I asked them if we could give them some extra counseling, it's one of the few times when I've gotten 25 out of 25. They all said no. They were not interested in counseling for their stimulant use. And 5 of the folks on buprenorphine said, if you make me go to counseling, I'll drop out of treatment and I'll go buy buprenorphine on the street. So the idea of forcing counseling seems like it's a very questionable idea, because these are folks who just don't see this as a problem, many of them. Now, there were a couple who had been in a contingency management program here at the University of Vermont. A couple had been in a drug court, or one was in a drug court, and they said that was helpful. But in general, they were not particularly treatment seeking for their stimulant use disorder. So I think that one of the challenges we have is to develop treatments that will attract patients in, because it will give them something they see as being useful. Right now, the idea that you go in and you talk to somebody about your life and your problems and blah, 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 that doesn't seem to be a particularly attractive treatment to them, to many of them. Here's some of the treatments. I'm going to talk about evidence-based practices. So to guide the development of a treatment system that can effectively address the serious public health crisis of methamphetamine, it's critical that the clinical strategies have the best scientific evidence. These strategies are called evidence-based practices. Evidence-based practices are those interventions that are grounded in systematic empirical evidence derived from research, guided by the standards of science. There's a whole bunch of definition of evidence-based. That one's one I like from a 2011 article. Okay, what are some of these things? Here's the punchline of the session. Contingency management is a technique that has overwhelming evidence of support. And interestingly, in the old days, I would have had to go back and pulled out articles and put them together and summarize them and sort of come up with some kind of ballpark guess as to what it is. But now there are groups around the world doing these meta-analyses and systematic reviews and network analyses. And there have been a bunch of them on cocaine, methamphetamine, and stimulants in general. And they all say basically the same thing. It's remarkable. If you're much of a research reader, you look at systematic reviews and meta-analyses, in general, meta-analyses often say things like, well, nothing really works that well, but here's some things where this one may work better than that one, or this one might have some mild effect, the power analysis may be somewhat positive. Here, it's very different. I mean, all of these reviews said the same thing unanimously and with great, robust conclusions, that contingency management is the one thing that has all of the evidence. There's some data to support CBT, some data to support community reinforcement approach. Motivational interviewing, there's been a couple of studies with people with stimulant use disorder. Not really enough to say that there's like a whopping evidence for MI, but I do have to say, when you're working with people with stimulant use disorder, motivational interviewing is a very handy language to have to develop any kind of dialogue with them. And I did some studies right before I left UCLA on physical exercise. Although that certainly can't be categorized in the same league with contingency management, it does have some positive benefits, some potential usefulness. This was one of the first of the meta-analyses, and Nico Clark is on here, who I know is back from WHO and is in Australia. But this was published in 2018 in PLOS Medicine, Comparative Efficacy and Acceptability of Psychosocial Interventions for Individuals with Cocaine and Amphetamine Addiction, Systematic Review and Network Meta-Analyses. They analyzed 50 clinical studies with about 7,000 participants, 12 different psychosocial interventions for cocaine and amphetamine addiction. And their conclusion was the combination of contingency management and community reinforcement approach was most efficacious and most acceptable treatment, both in the short and the long term. That was the first of these more recent. There were a couple other meta-analyses done in 2007, 2013, that said pretty much the same thing, but I'm only going to give you the ones from the last 3 years. This was published in Drug and Alcohol Dependence last year. They reviewed, this is non-pharmacologic interventions for methamphetamine use disorder, a systematic review. 44 studies reviewed, while contingency management interventions showed the strongest evidence favoring outcome. Tailored CBT alone or with contingency management was also effective. So there you get, so far with 2 studies, you've got both saying contingency management, one saying CRA and one saying CBT. This one, which was just published earlier this year in JAMA, this is comparison of treatments for cocaine use disorder among adults, systematic review and meta-analyses. They looked at 157 studies with 402 treatment groups, 15,000 participants. Only contingency management were significantly associated with increased likelihood of having a negative test result for the presence of cocaine. And I should tell you that some of my work back in the late 90s, we actually ran studies where we had equal numbers of individuals using cocaine and methamphetamine, and we got identical results, and so did several groups in San Francisco. So I think that the conclusions about treatment benefits for people who use cocaine and people who use methamphetamine are quite comparable with behavioral treatments. Medication treatments is different, but so I think that this study for individuals who use cocaine is another vote for contingency management. This was a review last year of 27 studies that all used contingency management for people with methamphetamine use disorder. The point of this study is that the impact of contingency management when used to treat people with methamphetamine use disorder doesn't just affect their methamphetamine use. Although they did see reduced methamphetamine use in 26 of the 27 studies, longer retention in treatment, more other therapy sessions attended, and higher use of other services, reductions in risky sexual behavior, increases in positive affect, and decreases in negative affect. So even though with contingency management, you may be simply providing an incentive for, say, a drug-free urine specimen, it has benefits that go beyond just the reduction of their methamphetamine use. This is a study about a population that's of great interest right now in the US. As you are well aware, US and the rest of the world, or much of the rest of the world, has had a massive opioid epidemic for the last 20 years now. And we've had great efforts expanding the use of buprenorphine and methadone to provide treatment for people with opioid use disorders. One of the things we're seeing is that when people are coming in using both opioids and methamphetamine, there's a definite effect on the treatment outcome. This was a sample, 800 patients. About 2/3 came into treatment just using opioids to go on buprenorphine. 1/3 came in using opioids and methamphetamine and went on to buprenorphine. These are the retention curves. The top line are the individuals who were just using opioids. And you can see if they go out, you retain about 50% for 2 years, more or less. But if you were also using methamphetamine, you see a very rapid drop off in the first 100 days associated with their methamphetamine use. Now, it's not clear to me, I've talked to the researcher and she didn't know the answer to this, whether these were dropouts or whether they were people being kicked out of treatment, because in our early years using buprenorphine 10 years ago, many of the prescribers would kick people off from buprenorphine if they continued to use any other drugs. That's changed, thank God. So I don't know if this first 100 days was people being kicked out of treatment or dropping out. I'm sure it's probably a combination, but certainly people using methamphetamine who are on buprenorphine or methadone, it does impact the effectiveness of those treatments. My colleagues here at the University of Vermont just published about 2 months ago an article in JAMA Psychiatry on contingency management for patients receiving medication for opioid use disorder, a systematic review and meta-analysis. Again, they looked at the literature that was available where contingency management was used to treat the stimulant use of individuals on buprenorphine and methadone. Their results were quite clear. These results provide evidence supporting the use of contingency management in addressing key clinical problems among patients receiving medication for opioid use disorder. Again, it's just one more in a long series of studies. And finally, the last one I'll beat you over the head with is this one from 2020. This is a review of reviews. So this is sort of one step back of the meta-analysis or systematic review. This is a review of a bunch of reviews. They reviewed 29 other reviews that looked at treatment interventions for people with stimulant use disorder. 11 other interventions, contingency management, CBT, and a bunch of other things. The strongest body of evidence was for contingency management, and there was not much to say about pharmacologic treatments. And other interventions found predominantly negative results. So there, I won't hit you with any more. This was a great article that your colleagues in Australia published in The Lancet in 2019. Mike Farrell was the lead author. And although they didn't do a systematic analysis of various treatments, at sort of toward the end of the article, they did a quick review of available treatment. And this sentence was sort of summarized their findings. Psychosocial interventions other than contingency management have weak and non-specific effects on stimulant problems, and there are no effective pharmacotherapies. So that kind of wraps up my overview of the literature as well. So contingency management is what we have that works. Now, I'm doing a lot of work on contingency management here in the US now. I'll talk about a project that we are starting that will start in next year, where a massive contingency management rollout. In preparation for that, I actually looked around the world because this literature on contingency management has been out there for quite some time. I mean, there were reviews in 2007, I think, saying pretty much the same thing. But it is the most well-established treatment that's not being used anywhere in the world, as far as I can tell, or used in a very limited way. I've been working with Anya at UNODC about whether or not there's anything that UNODC knows of, and she doesn't know of anything. Talked to my colleagues in South Africa, Southeast Asia, and a number of other, Canada, and everybody goes, yeah, well, we've seen the literature. Contingency management is got some real support, but we don't do it here. Why is that? Well, let me tell you a little bit about contingency management. It's a technique that employs the systematic delivery of positive reinforcement for desired behaviors. In the treatment of methamphetamine dependence, vouchers or prizes can be earned for submission of methamphetamine-free urine samples or attendance at treatment sessions. Those are the two primary paradigms where you're providing an incentive for people to give a drug-free urine specimen, or they give and specifically a stimulant-free urine specimen, or you're reinforcing them to do attendance at a treatment session. In most contingency management protocols, and this is, if we have time to talk about it, this is one area that I think is going to be getting some research. In most CM protocols, the value of the incentive goes up. Let's say you start with $10. That the person comes in, you meet with the patient, say, here's our program involves the use of contingency management. What that means is, if on your first visit, you give a sample that is negative for stimulants, cocaine or methamphetamine, you'll earn a $10 gift card, something like that. Then what happens is, if the person gives 2 in a row negative, the value can go up to $15 or $12. There's an escalation of the value with consecutive negative urine samples. Now, in part, all of the contingency management research I just reviewed uses this paradigm of escalating values with an attempt to get people to be abstinent from stimulants. Is that the most rational way to do it? I'm not sure, but that's how it's been used. If the person uses after 6 urine samples being negative and they give a positive one, the value resets to the original $10 and they have to take it back up again with a return. So there's this escalation and reset feature of contingency management. May not be the best way to do it for a harm reduction approach, but that's what has been done with contingency management. The basic philosophy of it comes directly from B.F. Skinner, operant conditioning. If you want a behavior to increase in frequency, you provide reinforcement. And that's all you're doing. Contingency management is the most simple intervention that conceptually that you can think about. I mean, we use positive reinforcement in all kinds of ways in helping change people's behavior, certainly in raising children and in getting people to go to work every day and giving them bonuses. Reinforcement is a big motivator of behavior. If you apply it to behaviors that are consistent with reduced stimulant use, you should get reduced stimulant use. That's the basic philosophy. In this case, stimulant negative urine drug test, you get an incentive. You should get more of those negative urine tests over time. Pretty simple. To be able to do it, you have a behavior that's objective, measurable, achievable, something you can get a quick snapshot. That's why we often use urine test results, because they're objective, they're measurable. If you use a point of care test cup, you get the result immediately, and you can provide the incentive immediately. For contingency management to work, the reinforcer has to be immediate. So you can't have a situation where the person comes in, they give their urine test, you say, okay, we'll get the result in a week. So we'll see next week if you get your incentive. that will dramatically reduce the effectiveness of contingency management. And you want to have an incentive that's something that is reinforcing to the individual. There's a long story that's too long to go into here. We've had a problem in the US using contingency management because our healthcare system was worried about it turning into fraud. And so they said, all right, well, we'll let you use contingency management, but only if the incentives are something that are healthy and are, I don't remember what the other words, but it was like, it got to the point where if all we could give would be broccoli and cauliflower and celery or something that, and I said at some point to these folks, you know, a reinforcer has to be reinforcing. It has to be something that the individual wants and will go out of their way to do something to earn. So as you're developing contingency management, it's really important to make sure that whatever it is you think the person should want is something they actually do want. So what we've done in the projects that we're doing now here in the US, they're all using stimulant negative urine drug screens as the target behavior. It gives you depending on the test cup, you get about a 2-day detection period. So if somebody gives you a sample that's negative for stimulants, you can be pretty sure they haven't used for the last couple of days. And so that's been the paradigm. People come in twice a week, once at the beginning and once at the end of the week. Can they sneak in a use in the middle? Yeah, probably. But what we're trying to do is to help develop some periods of reduced use. They only get the incentive when the test is negative. It's immediate. We're using gift cards. We don't give cash. Some places have used prizes. There's been one of the paradigms that's called the fishbowl method. We haven't, in the projects I'm working on, we're not using that. We're using a straight up gift card for the target behavior. And we're starting at $10 for the initial one. And our 12-week protocol, people can earn a maximum of $500. In most of the studies, we see people generally earn somewhere in the neighborhood of half to 2/3 of the maximum amount. So for example, in the project I'm going to talk about in California, the maximum is going to be $600 over 12 weeks that they can earn. And so it's considerable. And in order for contingency management to work, there have been studies on this. You can only go so low before it doesn't work because the reinforcer isn't powerful enough to sustain the behavior. As I mentioned, the contingency management protocols have this escalation bonus. The incentives get bigger with continuous abstinence, and they reset if if you get a positive test. Challenges, there has been resistance here in the US and in other parts of the world that we've talked about contingency management. The idea that people are getting stuff for not using drugs when they shouldn't be using drugs in the first place. I mean, that's a big problem in much of the US. I mean, right now, the states I'm working in are politically more liberal. Many of the conservative states, we've heard from some politicians, there's no way we're going to pay addicts to not use drugs. And that's sort of how that's one of the big areas of resistance. It can be somewhat challenging. You have to have a well-designed computer tracking system to make sure that the values that people get as the escalates and resets is all taken care of. And of course, the biggest issue is, where do you get $600 a patient to build contingency management? Where does the money come from? And that is a huge issue. Although here in the US, because of the death rate that we're seeing associated with methamphetamine/fentanyl, we're starting to get money put into this, and people are saying, how do we do contingency management? Just tell us how to do it and we'll start, and we need to do it because it works. So that seems to be getting better. Just a couple of words on some of these other things. The community reinforcement approach that was mentioned it really has only been shown in a couple of studies to be efficacious for people with methamphetamine use disorder. And Steve Higgins, my colleague at the University of Vermont, did these studies. It's a combination of behavioral strategies that really focuses on helping people with stimulant use disorder connect to new reinforcing activities in the world. How to set up so that you can get a job that you like and that you're doing new recreational activities so that your relationship with it's a very like a kitchen sink kind of intervention, in that it's got everything in it that counseling, marital counseling, employment counseling, recreational therapy, and there are some protocols written, and it does seem to be a useful approach, particularly when used with contingency management, but the evidence is not overwhelming. Similarly, CBT, I'm sure you're all familiar with CBT. It's a form of talk therapy based on principles of learning theory, used to teach, encourage, and support individuals in reducing or stopping their harmful drug use, provides skills, helps people change their thinking patterns, develop coping strategies. And Kathleen Carroll and a number of your colleagues in Australia have done great work with this. And there have been positive findings, but nothing nearly as robust as what we've seen with contingency management. I did a study, a 5-year study for NIDA right before I moved back to Vermont. We had individuals who were in a long-term residential program, who were there for chronic methamphetamine use, randomly assigned them. In addition to the therapy stuff they got, they also got either exercise 3 times a week for 8 weeks, a controlled thing with a trainer and a treadmill and all sorts of measurements going on, or they went to an educational class, a health education group. I won't go into the details, but we've published now, I think, about 12 papers out of this study. The last one just got accepted actually yesterday on craving, but exercise was shown to improve physical conditioning and reduce weight gain, which they often do in residential treatment, improve cardiovascular functioning as measured by an increased heart rate variability, reduce symptoms of anxiety and depression, reduce craving, enhanced recovery of the dopamine system. We did PET scans on individuals pre-post the exercise or health education condition. We saw a significant greater recovery in dopamine receptors in the exercise group. And when the individuals were discharged from the residential treatment, among the majority of patients, except for the very heavy users, there was a reduced relapse rate post-discharge. So I think exercise may have a role in treatment, but certainly it's still very early stage on that. Medications. These are the ones that here in the US that the National Institute on Drug Abuse is still quite positive about, and there are studies underway: topiramate and modafinil and bupropion, and amphetamine for treatment of cocaine use disorder. These are the medicines for cocaine use disorder. These are the 4 that seem to have the greatest interest. There's a lot of interest in amphetamine, controlled, doses of amphetamine for cocaine use disorder. But still, the findings are all mixed. The FDA has not approved any of these for the treatment of cocaine use disorder. We're also looking at a vaccine. Unfortunately, the vaccine for cocaine use disorder is taking quite a bit longer than the one for COVID did. For methamphetamine use disorder, similar situation in that there are no approved medications for the treatment of methamphetamine use disorder. The leading candidates are mirtazapine, which is an antidepressant. 2 double-blind trials on mirtazapine have shown it to be more effective than placebo. And 1 study on a combination of bupropion and naltrexone. This one was published to great hurrahs earlier this year in January, New England Journal of Medicine, big deal. But the treatment effect was pretty modest. 1 in 8 patients seemed to have a positive response, which was better than 0 of 8 in placebo, but it wasn't exactly a home run. And so I think that we still have a ways to go on medications for methamphetamine use disorder. Some of the other ones are listed below that where there have been mixed studies, some positive and some negative studies. And this is a systematic review and meta-analysis of medications for stimulant use disorder in patients with co-occurring opioid use disorder. This was just published about a year ago. There was no strong evidence that any medication was effective in increasing abstinence, reducing use, or improving retention. So we're still, I started the first paper I published on this, believe it or not, was a study on the use of dizipramine in 1981. And it was the first of a long series of papers I published on medicines that didn't work. I think I have the record of publications of medications that didn't work for stimulant use disorder. And we're still pretty much in the same place we were in 1981. Some of these things look promising, but nothing that comes anywhere close to the robust effects we get with contingency management. I mentioned implementation efforts in the United States and the Veterans Administration system. This is where all the individuals who have served in the armed forces go for their healthcare or can get free healthcare at the VA system. Contingency management is the primary treatment used in the VA for the treatment of people with stimulant use disorder. And it's used within their sort of closed system. People earn incentives for negative urine samples or stimulant negative urine samples, and they can cash them in their stores in the VA. So it's a sort of a nice system that's set up. They've treated in the neighborhood of 10,000 patients with contingency management, and I haven't seen any papers out of it yet, but I'm sure they'll be having some studies. I know the people running it say they're getting very good results. And as I mentioned, California is initiating a $58 million contingency management pilot project in 2022 to 2024, estimated to treat something in the neighborhood of 5,000 patients, as I mentioned, with a $600 CM program over a 12-week protocol. And there's some other pilot projects in a couple of other states that are currently underway. But I think that's all I have. I've got about 10 minutes. I told Steph that I would save 10 minutes for questions, and I'd be happy to take any questions you have.
Yes, thank you so much, Professor Rawson. That was a fantastic summary of the international literature. And it was really interesting to see the different levels of evidence for the approaches. At the moment in Australia, cognitive behavioural therapy combined with motivational interviewing is our current mainstay, but we have a lot of innovative trials looking into pharmacological therapies as well, which is good. We now have a few minutes for questions, and we're going to start off with a really hard question, Professor Rawson, and that is, what is the name of your cat? He gave himself a beautiful claim during your webinar, and that people were really interested to hear about.
Oh, I have 2 of them. They're brothers. They're about 15 years old. They're named Alpha and Beta. I think that was Beta that you saw.
Excellent. Well, thank you for that, extra bonus in the webinar, Beta. We appreciated it. So first up, has there been any longitudinal research into contingency management, and sort of what happens when those contingencies end?
Yeah, that's a great question. That's a really good question. And if you go back to B.F. Skinner, you would assume when you stop reinforcing a behavior that it'll go away and that people will return to drug use. There is some return to drug use. The studies I did a couple of contingency management studies right around 2000. My follow-up period was 1 year. So they had a 16-week contingency management program, but then I followed them at 6 months and at 12 months. I found there was, compared to the comparison groups, there was much less stimulant use, but it was more than at 16 weeks. There was some recovery of stimulant use, but it wasn't like everybody went right back to where they were. the idea that people, as they develop less use as a result of the contingencies, they start to connect back up with naturally occurring reinforcers in the world, or they recognize this was doing bad things to their life, and so they continue on continuing on with their recovery. That does happen with a considerable number of them. But there hasn't been, I just talked to my colleague Steve Higgins here at say, we need to get a postdoc or somebody to do a systematic review of that issue. To what extent do people return to stimulant use when the money ends? And I suspect you'll see that in some cases there's a pretty big recovery of the stimulant use, but in the studies I did, it was surprisingly sustained benefits from the CM. So it's a bit variable, and I can't give you an evidence-based answer to the question.
Well, thanks. I mean, yes, I guess it's something you would be great if you could get funding for that postdoc to do a systematic review. It would be really interesting. Similarly along that, I guess it's around a question on the different types of rewards and if there's been any research done into self-driven awards. I know that you touched briefly on, giving people broccoli and cauliflower probably isn't going to motivate them. But if they have some say over what rewards are involved in contingency management, does that have any effect on how well it goes?
Only anecdotal information that in some of the studies, one of my colleagues, actually, he was on published on that article with Mike Farrell. Steve Shoptaw has done a bunch of stuff in Los Angeles, working in the LGBT community. His patient population is mostly men who have sex with men who use methamphetamine. There, they had to tailor the incentives to the individual to get maximum benefit. So it does make a difference. I think gift cards for grocery stores, for store like Walmart, Target, that we have these stores where you can go in and buy almost anything. Although there have been, the California project is going to limit the gift cards so that they're not able to be used to purchase alcohol or tobacco. So there is that's a, and I'm not sure if that comes from our puritanical roots or from a good public health policy, but that's going to be part of the California project. But you do have to, it is good to talk to the patients about what it is they would want. Some of them, I mean, one of the studies I did, we were giving out, I don't know, gasoline credit cards to people. And we found out that this was at our clinic in Los Angeles. There wasn't one of these gas stations for 10 miles. And people were saying, this is stupid. I don't want this gift card. I can't use it. So you have to pay attention to get something people do want.
Yeah. And that kind of makes sense as well. If it's going to be something to motivate them, it has to be something right. That's beneficial. We have a comment from someone who's been reading systematic reviews, and they've said that in one of the articles that they read, they found a combination of contingency management and cognitive behavioral therapy was more effective than contingency management only. What do you think about that?
Well, that's actually two of the studies I did were exactly on that topic, and it's mixed. The literature is mixed. There are some that say that. The two studies I did, one was with patients on methadone who were using cocaine, and we used these interventions, and we tested CBT alone, CBT with contingency management alone, and essentially no treatment other than methadone. The two contingency management groups had by far the best results, but there was no difference between the two. The CBT didn't make a difference. I did it with primary cocaine and methamphetamine. Individuals use cocaine and methamphetamine, got the same result. No benefit from CBT over and above the contingency management. So there are studies that say it does make a difference. So I think it's a mixed literature on that.
Okay, so something we probably need to do some more research in and see where the field takes us. To change the topic a little bit, have you ever done any stimulant use disorder work in adolescents. Is there something that's particularly different about treating stimulant use disorders in adolescents or people in use?
There's been almost no specific research on it. That issue came up today in my discussion with the California folks about whether or not adolescent individuals who use methamphetamine would be eligible for this project that we're going to be doing. And the answer was yes, that they would. And then we get into the whole thing, do the parents have to give consent? And there's a whole issue around that. But I think from my colleague, Rachel Gonzalez, who does adolescent research and looks at interventions, she did some stuff with a pilot with contingency management with adolescents and got very strong findings. And it was something that the adolescents really liked. It was, again, they weren't particularly interested in any kind of counseling form of therapy, but this idea that they could earn, I think they were giving out pizza coupons or something like that. And in this pilot project, I think contingency management is very well suited for adolescents as part of an array of treatment. I mean, I wouldn't want to have it be the only thing, but yeah, it provides a reason for people to go into treatment who are ambivalent about whether or not they really want treatment, even if they just go in because they want to earn some stuff. At least you have an opportunity to talk to them.
Yeah, that's a great point. I guess on that kind of is a question that came through around what would be effective for people in correctional centres or prisons. I guess is there a kind of contingency management in that situation, or is there any sort of research that's been done on what might be effective in those situations?
Yeah, it as far as I can tell, and that issue has come up as well. Where the people are wanting to use the contingency management is in the discharge programming. I mean, I guess you could use it in a prison setting for management, but the real place they need it applied is the day they walk out the door, and the day that they're you really want to try to influence their behavior. Some incentives, a powerful incentive program that will link them to sober living and that kind of stuff may be very useful, but there have been no studies on it as far as I know. I think though that if you're really interested in applying contingency management to that population, focus it on what happens when they move back into the community, not so much what happens inside the institution.
Okay, thank you for your comment on that. That's it's definitely a difficult thing to think about. Just to finish off, there's a question that's come through about in your research and in your readings, to what extent has trauma-informed care and approaching been incorporated into evidence-based treatments for methamphetamine?
Yeah, it's good. That's a good question. I mean, there's a good literature on trauma-informed care, and it is getting increasing use, I think, in many of the treatment programs in the US, not just for people with stimulant use disorder, but with people with a variety of substance use disorders. The data tend to be a bit fuzzy in terms of their the randomized clinical trials have not been as clear. The results have not been as clear as, say, for contingency management. But I do think that there's no question among our population, trauma is incredibly high, and those therapies certainly appear in qualitative studies to be very valued by the patient population. So I think it's great that those are being adopted. The evidence for them is a little softer, but I think that they definitely, certainly used together with contingency management, could be a good combination.
Yes. Fantastic. Well, we're actually out of time and there's still many questions left over. So I'd just like to thank everyone for sending through their questions. and also apologize to anyone who didn't get their question answered today.
Steph, can I interrupt you?
Yes.
You can send me those questions in an email and I'll answer them and send them back to you.
Okay, that would be fantastic. Very happy to do that.
Okay.
Yes, so just to finish off, I'd just like to really thank Professor Rawson, particularly because it's 7 o'clock over in Vermont. So thank you so much for giving up your night to talk to us. And thank you to Alpha and Beta for joining us and for an extra presentation. We appreciated it. We'll be holding more webinars and new resources on cracks in the ice throughout the year. And so I'd like to encourage you to subscribe to our mailing list if you would like to receive future updates. Thank you all again for joining the webinar today, and thank you so much, Professor Rawson. I hope you all have a wonderful rest of the day and a good night's sleep for you, Professor.
Thank you very much.
Thank you.